I got it online from my friend that has her online radio show. I probably got it. It's 3 bars sleep and it has like a long, yeah. It has a long bus. Everyone wants a long bus. Yes. Yes.
Okay.
Yes.
I have a look to make sure I got everybody's, I got a lot of questions from people. I haven't yet gone down the list to make sure I got it from everybody, but I haven't read them all. I've read a lot of them. And I think we're all happy that you're not answering your colleagues' questions on the quiz. Some of you went above and beyond. And there's some questions I was like, oh, great question. And I'll be, de-identifying them and using, if I'm doing this next year, using many of them as review and discussion questions. But wow, there's some tough ones out there, and there were good ones. And I'm sure you all just thank the world and love Kelly, but if she ever invites you to a reunion, do not go. Do not go. It's a dangerous place to be. She developed a scenario with several of you, and not everybody makes it out in good shape. You don't go to sleep when she writes questions. Okay, so let's get over here to the quiz. Okay, please put your name on top. Today is December the 8th.
Oh, I won one of those things.
And we'll see if we can get through this pretty quickly. Think. Okay, you have 60 seconds. 60 seconds to consult with anybody in this room except me. Go.
I don't know.
And I said B.
Yeah.
I think it is this fully reabsorption.
What do you have? Maybe B.
Isn't it?
No, it's A. It's the last one.
Most of it gets either, because that's what I was thinking too, right after the more or less, right? Most of it already gets 85% of it gets right there.
Yes, it's A.
Right. Yeah,
I was here for the.
I knew it was right after the GFR, but I wasn't like.
No, right. Last one's for sure A.
Right.
2, I guess, then B.
10,
Yeah.
5, 4, 3, 2, 1. Splash down. Okay, hand into the inside. Now remember, when you are a practicing professional, talk to your colleagues. Where nobody's expected to know everything at all times.
Oh,
It was the 8. Should we get
is it 8? We're anywhere from next week to last week. Bro, you know, we'll be gone. Oh, it's I was like, what are we here?
What do you think about number 1?
We don't have any other classes, right? Other than
So go blank, so goes the kidney. So the reabsorption of glucose, what is it chained to? Sodium. Reabsorption of all the amino acids. Sodium. Sodium cotransport. Water follows sodium everywhere in the nephron with the exception of one place, lactate. Bicarbonate. Bicarbonate is actually, you need to have sodium movement to move protons. So sodium reabsorption is very important there. Number 2, what looks good here? Which letter? Tell me. B, I agree. This one, I hope nobody got tripped up. What's the correct answer? A, proximal tubule. Yes, the collecting duct is sensitive to ADH, but 2/3 of the water is reabsorbed in the proximal tubule with or without ADH. So that's the area of the greatest reabsorption of water. So,
B.
So now, very quick recap of what we looked at last time with normal, healthy individuals. If your plasma glucose is too low, one thing that you have working for you is pancreatic alpha cells will release glucagon, and that will cause the liver. Glucagon causes effects throughout the body. It will cause you to release fatty acids into the bloodstream, so other cells throughout the body can utilize fat instead of glucose for energy. It causes the liver to break down stored glucose that's in the form of glycogen and release that glucose into the bloodstream, so it stimulates glycogenolysis. It also stimulates the liver to make brand new glucose molecules from non-carbohydrate precursors. That's called gluconeogenesis. So if your plasma glucose is low, the hormone glucagon gets it back up to normal in a number of different ways. And if your plasma glucose is elevated, insulin is released from pancreatic beta cells. It goes out and binds receptors throughout the body, and insulin tells cells throughout the body to do many things. It stimulates many different actions, but the one thing that we were talking about here is it stimulates the movement of GLUT4 glucose transporters that are sitting in the Golgi, and when insulin binds its receptor, it sets off a signal transduction mechanism that causes GLUT4 glucose transporters to come up here to the surface, and that allows glucose to come into that cell. So that is insulin-induced glucose uptake, but it's being made possible by insulin telling that cell, bring those transporters up to the surface so this glucose will come in. So insulin is really it's a signaling hormone, obviously, but it's telling cells that, hey, there's glucose out here. Take it up, take it up. And this is an example of an insulin-sensitive cell. Okay, so we did get a little bit through looking two major forms of diabetes, how it's classified now, although in the next few years I think that classification is going to be broadened a little bit. But type 1 diabetes. Type 1 diabetes used to be called they started going away from this 20 years ago. It used to be called juvenile onset diabetes. In fact, a British paper was published about 6 weeks ago documenting that close to half of type 1 diabetes it's diagnosed after age 20. So it's not juvenile onset. It used to be called juvenile onset because when it came on in juveniles years and years and years ago, it was bad. There wasn't much you could do for those kids 100 years ago. And by their mid to late teens, they often died. So juvenile onset diabetes, that's the old term. Now it's diabetes type 1, so TIDM, type 1 diabetes, and then IDDM stands for insulin-dependent diabetes mellitus. Type 1 diabetics rely on exogenous insulin. Insulin taken in from outside the body, taken in. So we're going to talk about this here in a second. So type 1 diabetics have a lot of problems. Their main problem, they don't have insulin. Second main problem is that causes them to have too much glucagon. So with a type 1 diabetic, what's going on is there's an immune-mediated loss of beta cells. For whatever reason, the body recognizes the beta cells as foreign cells and they are destroyed. So the glucose sensor, the insulin producer cell, wiped out. So in full elaborated type 1 diabetes, there's very little circulating insulin in those individuals in stage of the pancreatic beta cell destruction. So if you don't have insulin in an untreated type 1 diabetic, you're not going to have insulin-stimulated glucose uptake. So here's all this glucose, and here are these insulin-sensitive cells, and they don't know all this glucose is out there. So they aren't translocating those GLUT4s up to the surface to allow that glucose to come in. So with type 1 diabetes, there's a diminished insulin-induced glucose uptake by insulin-sensitive cells due to the lack of insulin. So skeletal muscle and adipocytes make up a large part of your body mass, and they are insulin sensitive. So a large part of your body mass loses the ability to easily take up glucose due to the actions of insulin because there's no insulin. They're perfectly insulin sensitive. These things are fine. It's just there's no insulin in an untreated type 1 diabetic to tell those cells to take it up. Now, you give this individual insulin, they take it up just fine. Take it up fine. So it really diminishes this insulin-induced glucose uptake. There's other ways of causing glucose uptake, and I'll talk about it here in a little bit. So this used to be called, and I showed you pictures at the end, starvation and sea of plenty, going way, way back when. This type of diabetes, it's interesting that this was described very, very well more than 2,500 years ago with ancient Greek physicians. There were certain individuals that would become ill and they would start wasting away. The fat on their body would diminish, their muscles would begin to atrophy, and oh, it's interesting, they're urinating all the time, they're drinking all the time, they're hungry all the time, and something else, when they would urinate, it would attract flies. See if you would do this. You all are going to go to the wall for your patients. I know you will. Well, those ancient Greek physicians went to that urine and went, sweet. They knew their urine tasted sweet. So way back when, would you do that? Yeah, good luck with that. but they, and you know, this is really where that diabetes mellitus, dia means through. and the beet means sweetness. So there's a sweetness that's going through their body and coming out in the urine. And literally, in an untreated type 1 diabetic, this glucose gets so high, it starts coming out. You know, our kidneys have a huge capacity to reabsorb filtered glucose, but it's not infinite. And your plasma glucose gets high enough, this glucose is going to start not all being 100% tubular reabsorbed in the kidney, so it's going to be going out in the urine, and glucose has OH groups, it's going to pull water with it. So somebody's going to have a diabetic osmotic uresis. They're losing glucose in the urine, it's drawing water with it, they're hungry all the time, they're drinking all the time, and they're wasting away. And later on, when they were able to start measuring glucose in the bloodstream and seeing it, it was just, the bloodstream just loaded with this energy-rich molecule. It was described as starvation in the sea of plenty. There's plenty of energy in circulation, but these patients' bodies are starving because these cells aren't getting a signal to take up the glucose. Now, the other huge problem with these patients, and it leads to a number of detrimental things, is they become hyperglucagonemic. Hyperglucagonemic. Now, why is that? Yeah.
Quick question about you're saying that if you don't have diabetes, is there enough sugar that you can eat that you would start urinating sugar? I'm just like, is there a point where the body would not be able to produce enough?
You haven't read the sheet yet.
No,
You'll find that out.
Okay.
You'll find that out. Yeah, you will find that out. Years and years ago, even when I was I'm an older guy now. I'm not that far from 60. But when I was a little kid, people talk about, oh, so-and-so's got the sugar diabetes. They would look for sugar in the urine. And you don't see glucose in the urine until your plasma glucose is like 270, 280, 290, something like that. It's very, very high. When do you start worrying about plasma glucose and moving from pre-diabetic to diabetic? 126 or so. So glucose in the urine is a very poor diagnostic indicator because somebody has been probably full-blown diabetic for a long time before you ever see it in the urine. So why is this hyperglucagonemia taking place? Now this relationship occurs in normal healthy people, and it also is found in, you do have this, right?
Yeah, it's,
okay.
It's just back.
I want you to just focus on this right here. We're not going to worry about this. But insulin, when it's released from beta cells, insulin inhibits the release of glucagon from alpha cells. Now, glucagon causes a little bit of insulin secretion, okay? So, in a normal, healthy person, insulin is putting the brakes on glucagon secretion, okay? Now, when we were talking about in a normal, healthy person, if you are hypoglycemic, yeah, the alpha cells release glucagon when you're hypoglycemic. And I said it's indirect. It's because in a normal, healthy person, when plasma glucose is low, plasma insulin is low. So when plasma glucose is low and plasma insulin is low, it's like insulin takes the brakes off of the release of glucagon. Those pancreatic beta cells, in releasing small amounts of insulin in that local environment, in the pancreas, that insulin is like putting the brakes on glucagon secretion. So, if your plasma glucose goes low, insulin secretion decreases. What happens? That allows these alpha cells to start releasing glucagon. And what's that going to do? That's going to help increase your plasma glucose. So do you kind of see how via insulin, glucagon can react to hypoglycemia? They do have the ability to react in a test tube to hypoglycemia directly, but not very strongly. What they really react to is if there's a lack of insulin, it causes a release of glucagon. If there's a lot of insulin, it completely inhibits the release of glucagon, okay? That's happening in a normal, healthy person. This is also going to become very important in type 1 diabetes. Because in type 1 diabetes, if you lose your pancreatic beta cells, what's that going to do here? You're going to lose this inhibition. So what's going to happen? Huge release of plasma glucagon. And what is one of the things, and boy, glucagon does a lot of things, and there's one very last slide, I doubt we'll really talk much about it, because I don't know your background in biochemistry. But one thing glucagon does that you saw from a slide before, it signals the liver to start synthesizing new glucose and putting it in the bloodstream. Do you think that's going to be of help to a type 1 diabetic? Their glucose is already too high. Their glucose is already too high. So here we have a type 1 diabetic who's lost their beta cells. They don't have insulin, so that causes hyperglucagonemia. What's that going to do? It's going to increase gluconeogenesis, and they're going to have even more glucose in circulation. That's bad in an untreated type 1 diabetic. So hypoinsulinemia is a big problem, but it also causes hyperglucagonemia, which is another big problem. And I just told you one of the problems with hyperglucagonemia. Now you give this individual insulin, okay, insulin tells the glucose to go into these cells. Remember, too much glucose for too long, you start glycating proteins. That's not good. That's going to lead to, it's going to disorder polyol metabolism. You're going to get tissue damage. So you give this person insulin, glucose is going to go where it's supposed to go, inside the cell. It'll decrease damage, and it's going to inhibit the release of glucagon. So a lot of things start working right when you give those type 1 diabetic insulin. So with a type 1 diabetic, the problem's right here. This is where the deficiency is. You lose your pancreatic beta cells. That's where the sensor is. You have this slide coming up later. You lose your pancreatic sensor and your insulin releasing cell, the beta cells. So here is a picture. It's not in your book, but I'm using it. One-time educational use only. It used to be thought that, and it is true, that in type 1 diabetics, symptoms tend to come on pretty quickly. And, you know, here's Alex, he plays soccer, and all of a sudden he's feeling run down, he's feeling tired, and bruises on his legs, which normally would be gone in 3 or 4 days. They're sticking around for 3 or 4 weeks. He's getting skinny, he's eating a lot. Well, we have in our body, we're built in with a lot of beta cells, So this kid has a lot of beta cells and a lot of potential for releasing insulin. So this is the person's insulin secretory capacity. But there's some immunological trigger that happened for some reason in this person's life, and their beta cells start being attacked, and their insulin secretion capacity goes down. But this person's not going to have any signs or symptoms because we have so much insulin secretion capacity built into us. We have a physiologic reserve of beta cells that it's not until you hit this clinical threshold when suddenly you don't have quite enough beta cells to release enough insulin that signs and symptoms really pop up very, very quickly. in a matter of weeks or months. And it doesn't mean that that disease process just started weeks or months ago. It started quite a long time ago. You just have such a physiologic reserve, it takes a while to where you can get to the point where clinical signs and symptoms are manifested. And you know, you can then observe these things. Patients will report those symptoms, you'll see the signs. Boy, a lot of people have type 1 diabetes. I need to update this. This woman, she's an actress, she must be in her 80s now. She, for years and years and years, even when I was a kid, she was the poster person for type 1 diabetes. And she headed up the juvenile diabetes. Well, she was the face, the spokesperson for the Juvenile Diabetes Foundation for a long time. These people were on the singing show that is no longer around, American Idol. I put this up for a reason, because, man, that was a dangerous show. There was type 1 and type 2 diabetes all over the place. I put these two people up because during the show, they both ended up in the hospital because of suffering some symptoms as a result of their type 1 diabetes. Jay Cutler, boy, you either love him or hate him, and 90% of the people in Chicago hate him. The point is, I threw him on there as type 1 diabetics can be so well controlled now. Obviously, you know, a poorly controlled diabetic, tissue damage, you saw the damage to feet, and poor wound healing. Well, type 1 diabetics now can be controlled usually very, very well. There are some who aren't very well controlled, but most can, you know, there's guys who play collision sports. He's since retired. He's now retired. Gary Hall, he was interesting because when he was a teenager, he qualified for 2 Olympic teams when he was a very young teenager. He medaled the first time he went to the Olympics. Second time he went to the Olympics, he got a gold, an individual gold, and I can't remember, and I think a relay gold, and then he got sick. A year afterwards, he got sick, and it took him a while to go see the doctor, and he was a type 1 diabetic, and it took about 2 more years for him to regain his strength and muscle mass, and he came back to a later Olympics, and I can't remember if it was 4 years later, if it was 8 years later. I think it was actually 8 years later, and came back and medaled and did very, very well post-diagnosis. So I need to update these a little bit. There's some actresses and so forth. Here's some, one of the justices on the Supreme Court, Sonia Sotomayor, you know, I really admire people who put themselves out there and say, you know, hey, I have this, I'm living with it. Well, she goes and she talks 3, 4, 5, 6 times a year, it sounds like, with these children's groups of newly diagnosed type 1 diabetics. You got to be careful for that water. It'll get you. It'll get you. Well, here she's talking to 150 children, and she says, so here she was 7 years old, and all of a sudden she started wetting the bed. She hadn't wet the bed, and all of a sudden she started wetting the bed, and I was so ashamed, so on and so forth. Well, so here's a justice of the Supreme Court that regularly goes talks to kids about, all of a sudden I became a bedwetter. And it turned out, yeah, I have this disease that you were just diagnosed with, and guess what? I'm okay, you're gonna be okay too. And you know, I really admire people who put themselves out as examples to especially let children know that you're not alone. There's a lot of us that go through this. So to this day, she's poorly controlled. Well, she's not poorly controlled. She's well controlled, but she has to inject 4 to 6 times a day. So, a little bit of history. Need to cut this kind of short, but here is Leonard Thompson. This was the first person to be given a crude injection of insulin. Did it work? Well, that picture was taken 20 years after the first injection, so yeah, it worked. And so he was injected on the 11th of January, 1922, so we're not that far away from 100 years ago. Here is, this guy, he was a British physician, Frederick Banting. He grew up in a neighborhood. One of his childhood friends, all I remember his first name was Jane. She was a type 1 diabetic, so in his childhood he saw her wither away and die. And he went to medical school and he became a surgeon, and it just always was in his mind, man, I need to be able to do something to help kids like my friend Jane. And he woke up in the middle of the night and he had an idea. He'd been reading some papers, and it's always good to have a notepad or even have your phone to type into the notes when you wake up with a great idea. Well, I think we need to do this because there's something in the pancreas that's now been shown. So this guy, McLeod, he was a physician working in Toronto. So he was Banting was sending letters to McLeod asking, can I come to Toronto and work in your lab because I think I have an idea on this. And he kind of put him off, and Banting turned out to be very persistent. And about 6 months later, he says, yeah, come on over. Matter of fact, I'm going to give Charles Best, he's one of the grad students working in my lab, he can work with you. So it was, it was the night of October 20th, he woke up with this idea. So he comes over in late 1920, well actually it was the middle of 1921, and they start getting crude homogenates of the pancreas from cattle and hogs. And there are dogs that have type 1 diabetes, and they were giving it to those animals, and the glucose release from the urine stopped immediately. Now there were some problems in the homogenate they were doing, because imagine your liver has all sorts of digestive enzymes too, and it also has glucagon in it. So, but there were these positive signs. Well, very, very soon, it was less than a year after they started doing these experiments, they gave the injection to old Leonard here. He immediately benefited, but by the 3rd or 4th week, he was starting to react to the injection. And so they got Collop, he's a biochemist, said, well, let's see if we can fraction out all of what's in these homogenates and find really the part of this homogenate that's working. Then we can get rid of all the stuff, and hopefully we will get rid of the bad stuff. And that's what they did. So they did a tremendous amount of work in 6 or 7 months. And anyway, these two guys got the Nobel Prize, and Banting was so furious that Best, who actually did most of the work, the graduate student, wasn't named by the Nobel Committee. He gave half of his prize to Best, however much money that was, and that kind of embarrassed McLeod, so he gave half his money to Collop. so you know, but it made quite a difference. So this was published in December of 1922. So he woke up in October of 1920 with the bright idea. He worked for 4 to 6 months to get McLeod to allow him to come over, talking about Banting, to, can I do these experiments? And they're doing these homogenates. To, here's a paper that was published the end of the year after he got over to North America to start doing the experiments, and I showed you these pictures. So here's a young girl, here's a young boy, and this is what their phenotype looked like. They just, they're starvation victims, except their bloodstream just loaded with glucose. They are starving in the sea of plenty. And then here is a girl, she got insulin for 4 months. She was one of the first ones to start getting Collop's fractionated, and I can't remember if it was pig or bovine, cattle insulin she was getting. This is him after 3 months, and you can just see totally different kids. They're not starving to death. So this is one of the medical marvels of really all time. These kids they became what would be called brittle diabetics. They bruise easily, get infections, and they tended to die in their if they contracted before age 10, they tended to die by their mid-teens to late teens. So all of a sudden, boom, they went from that to that. Just like that. Just like that. So here is something I really want to take some time to talk a little bit about. Diabulimia. How many of you have heard this term? Really? This is not a clinical term. You did not learn this. This is a term used in the popular press. But diabulimia is associated with insulin misuse, or it's actually underuse. And this is something that is going to be an important part of many of your professional lives in just monitoring your type 1 diabetic patients. So, and this has been around now for quite a long time. This was the first paper I read in 1999. And I've since found a paper in 1995 that was talking about it. And I bet if I go back, I'll find even more. But imagine, if you will, you saw how these kids plumped up. Well, what about if you're a young person, you are newly diagnosed when you're 12, 13, you're just skinny, emaciated, and you start taking insulin and you plump up. And you go, I'm too fat. I'm weighing too much. Well, these kids are bright. They know that, you know, if I don't take quite as much insulin as what I'm supposed to, I lose weight. I lose weight. So this is really insulin restriction to help lose weight. In the popular press, and the Times of London just had an article a couple months ago about a whole slew of young women dying. So this term popped up again in the popular press, diabulimia. And so here was the first one I looked at, 76 adolescents, males and females, and what they found in this study, and this is it's coming up to 20 years ago, 30% of the females were underutilizing insulin for weight control. 30%. Guess what? Study after study after study keep finding 20 to 35% of females underutilizing insulin for weight control. And that leads to diabetic complications. All those bad things that happen with advanced glycated end products, disordered polyol metabolism, all those things, all that damage to tissue occurs if somebody underutilizes their insulin. So the first time I really talked about this in class that I remember was in 2007, so 9 years ago. So I was talking about this in class, and a young woman in class said, oh, she said, Dr. Crouch. And she's reaching through her backpack, and she pulls out People magazine. And I admired her for admitting that she reads People. And she said, look what's in this week's magazine. And it's just a dangerous new diet, a dangerous new diet. And so it's not a diet. It's just type 1 diabetics underutilizing insulin, and it allows you to lose weight. Plasma glucose goes up, it starts spilling out into the urine. You're losing calories via the urine. You're going to lose weight. Wow, this is great. But it's not. It's not. Now, I don't want you to think that this is busy work. This is very important to me that you understand this, because since I started preaching this to dental students, they come back to me either when I see them at continuing education courses or even when they're in school, and they go, man, I'm working with a type 1 diabetic and I'm concerned what we talked about in class is going on here. I've got a young woman and she's thin. 2 years ago, she was not thin. And and typically, there's nothing typical in the world, but commonly what happens is children, these young people are well controlled when they're living at home, then they go away to college, and they come back from college svelte. They've lost weight. And they think they look good. Well, maybe they do look good, but the inside of their body is just being torn apart. Okay? I posted, it's just 3 popular press articles. They're actually all from, I think, 2007 or thereabouts. And 2 of them are written from the perspective of the patient. This one is purely written by this young woman. And so she made it to the hospital 3 times. The last time she ended up in the hospital due to diabetic ketoacidosis, her plasma glucose was 1,040. What should it be? 70 to 100 or thereabouts. It can be higher, but she would be when she'd go to her dentist or stuff like that, and they'd say, "Well, what's your glucose numbers like now?" "Oh, I take my finger stick blood sample. It's about 120." And she said, "Really, it was 700." I'm going to show you about the hemoglobin A1C. Her hemoglobin A1C, the last time she got sent to the hospital, was 18%. And here's the equation for estimated average glucose for the previous 3 to 4 months. Her average glucose was 470. Now, she was a lot lighter, a lot thinner than when that happened and this picture was taken. This picture was taken when she wrote this. So if you look, there's just 3 articles and they're very, very short, and they're diabulimia articles. Once again, that term is not a medical accepted term. It's called insulin misusage or insulin underutilization. But I want you to read these popular press articles to just get an idea, and especially from that woman. This isn't popular press. This was an American Family Physician. She did a first-person account. And you hear about these people, and it's considered an eating disorder. It's within the realm of anorexia nervosa, bulimia, insulin misusage, and exercise, over-exercise syndrome. They're all in that area of emotional disorders. So what is the consequence of chronic diabetic misuse? You're not going to be able to see this very well. I'm going to glue this up a little bit. But once again, this was a study, insulin restriction and associated morbidity and mortality in women with type 1 diabetes, and it looked at 234 women over a number of years, and a number of these women, they knew what happened. So some women are insulin restrictors and some utilize insulin as it should be. Insulin restriction conveyed a 3-fold increase of mortality after controlling for age, body mass index, and hemoglobin A1C. Mean age of death was younger in insulin restrictors. Insulin restriction reported higher rates of nephropathy, kidney problems, and foot problems. Deceased women who died over the course of this study, had reported more frequent insulin restriction and more eating disorder symptoms. So this is a real problem. And I keep seeing this 25 to 35% of young women who are type 1 diabetics or insulin restrictors. I don't know if that holds up population-wide, but I keep seeing those numbers. That's a lot. That's a lot. It's not seen nearly as much in males. There is one group of males that it might be a little bit higher in, but it's more common in young women. So if you want to learn more about it, when I want to learn about diabetes stuff, the Joslin Center for Diabetes, which is associated with Harvard Medical School, and I can't think of one of the hospitals just right close to there. I've walked past this place before. It's a great site. You know, oftentimes you need to put a picture to something to really understand it. This is the first person that I really knew that kind of put a face on it. This young woman, she was diagnosed with type 1 diabetes when she was a child. She was the heir of, Johnson & Johnson, maker of pharmaceutical products and home healthcare products. She died due to the effects of diabulimia, And interesting thing, well, it's a tragic thing, is she and her father, when she was young, wrote a book together, Managing Your Child's Diabetes. So her dad wrote how the family was dealing with it, and as a little kid, she had areas where she wrote how she dealt with it, and what she thought about it, but she never was able to break out of this cycle. So, nasty, nasty stuff. So, let's now switch to type 2 diabetes. Type 2 diabetes, similar to type 1 diabetes, there's inappropriate hyperglycemia. Inappropriate hyperglycemia. That is similar. Now, so type 2 diabetes, it used to be called, up to 20 years ago, and now it's been phased out, adult onset diabetes. It's really been phased out in the last 5 years because there's been an incredible spike in type 2 diabetics in younger teens, and I just, less than a year ago, looked at the incidence of type 2 diabetics and diabetes in children under 10. It's a huge, it's like a 10-fold increase today versus 10 years ago. Huge increase. So it's called type 2 diabetes or non-insulin dependent diabetes mellitus. Now, a lot of you know people with type 2 diabetes and they may take insulin. So you go, well, why is it called non-insulin dependent type 2? Well, they don't, with a type 1, you have to give them insulin or they will become sick and die. With type 2 diabetes, there's a lot of other medications one can give to help stabilize the signs and symptoms and glycemic control. And sometimes insulin turns out the best thing to use, or at least one of the things. The problem with type 2 diabetes, you have a decreased sensitivity to insulin. Insulin will bind its receptor, but its signal transduction capability is decreased due to a decrease in tissue sensitivity to insulin, and that's closely associated with diet, physical activity, and obesity. Those are, and genetics play a role too. Genetics definitely play a role, but diet, physical activity, and obesity are associated with this development of tissue resistance or insulin resistance. So you hear it called insulin resistance or tissue resistance. Bottom line is this tissue is not reacting to insulin like it used to. There's not as much signaling capacity. So one of the things we talked about was getting those GLUT4 cotransporters up here to the surface. It doesn't do that nearly as well. So there's much reduced glucose uptake in these individuals. So it doesn't mean that completely stops. It does slow down. The signaling capacity to tell this cell, oh, get GLUT4s up here, it's diminished. So there's diminished glucose uptake in adipocytes and skeletal muscle primarily. So the hyperglycemia persists because it's not being taken out of the bloodstream. So type 2 diabetes, the ability of insulin to activate glucose uptake is diminished. It is diminished. Now, before I have another slide coming up that, yes, in a normal healthy person, insulin will cause glucose uptake. But in a normal healthy person and in a diabetic, physical activity in and of itself will activate a different signaling pathway, causing those GLUT4 glucose transporters to come to the surface. So there is an insulin independent mechanism associated with physical activity that will cause that GLUT4 glucose transporters to come to the surface. So the Scandinavians do all sorts of interesting exercise physiology studies. Scandinavians will allow really dramatic studies done on them, but you can put in indwelling femoral artery and venous catheters on a right leg and left leg, and you can have a person exercise one leg for 4 hours and the other leg is resting, and you can look at glucose and fatty acid differences going across the muscle. But interestingly, when you take a muscle biopsy, the exercise leg will have a large amount of GLUT4 glucose transporters on the surface. On the non-exercising muscle, it doesn't. So acute exercise training, doing exercise at least every 48 hours, both of those will cause GLUT4 presentation on the surface to go up, and if you train, do it exercise at least every other day, you actually stimulate the synthesis of new GLUT4s, so you're putting more and more in the Golgi. So that's why physical activity is beneficial in type 1, type 2, and all people in helping to preserve glycemic control, because that's not using insulin. That's an insulin-independent mechanism to get GLUT4 to come to the surface and to allow glucose uptake. So that doesn't require insulin to do that. I do have a slide coming up here. So I mentioned that type 2 diabetes associated with diet, physical activity, and obesity. Here we have the prevalence of diabetes in the year 2000. And the darker the shade, the more diabetes. Here it is 10 years later. That's kind of scary. Now take a look. Up here is, down here is diabetes from 1994 to 2010. Here is the rate of obesity. And it appears that diabetes follows obesity by 5 to 7 years. So as obesity goes up. Now, interestingly, I just saw the 2015 numbers, and you saw how there's a spike in type 2 diabetes that was considered, it was thought it was going to last at least until 2021 at that trajectory. It's actually starting to round off a little bit. It's starting to round off a little bit. And it's associated with the obesity rate is starting to, it's not coming down, but the rate of increase is slowing down. The rate of increase, it's still incredibly high, but it's starting to slow down just a little bit for diabetes. We'll see if that keeps up. So it was thought that this curve was going to be maintained to about 2020, and maybe 2021, but the curve is starting to round off just a little bit, maybe. Hopefully that's the case. Hopefully that's the case. Like I mentioned, you go to Gateway Mall and you throw a wiffle ball in all directions, you're going to hit a type 2 diabetic pretty easily. He was on that singing show. He had a different form of diabetes. So a lot of people have diabetes. I need to update this. You know, B.B. King, I loved him. When I lived in New Orleans, I got to see him quite a few times. Got to see him here once. He earned his diabetes. He really did. You know, a good blues man earns his diabetes. Now, of course, Paula Deen, if any of you ever watched her cooking show, a little bit more sugar, a little more butter, you know, she was, you know, there were a lot of reasons why people got mad at Paula. But one thing is, and you know, this one, it was like, oh, she was diagnosed as type 2 diabetic, and here she's making these pro-diabetic recipes on TV, and she never told anybody until she signed with a pharmaceutical firm for a new diabetic drug. And then 2 weeks later, she says, oh, I have type 2 diabetes, and yeah, I want you to. Well, of course, when certain views that she and her brother have came to light, that company dropped her immediately. Tom Hanks, an actor, this is one of those things that you just couldn't predict would have happened. I think this was 4 years or 5 years ago. He phenotypically does not look like somebody who would get type 2 diabetes. But over the years, his glycemic control got worse and worse, and he was finally diagnosed with type 2 diabetes, even though he was doing everything right. And so he goes on Dave Letterman's talk show, it was just 2 weeks after he was diagnosed, to talk about it. And there was something very interesting, and there were papers written on this. For the next 6 months, guys his age, guys my age, started to go to their doctors for physicals. So here was a guy who a lot of people his age identified with, going, well, if he's got a problem, maybe I have the problem. And there was this huge increase in number of guys his age, my age, who went to see their doctors, and papers were written about how many folks were identified and now being treated for their diabetes, or they were high pre-diabetic, and there's something you can do about it. And because of him just going on Letterman and talking about it. So he did a public health, that was, public health, almost service announcement, so to speak, Here is just looking at the time course of what happens with diabetes. Now, the type 1 diabetes, you lose the ability to secrete insulin. Look at type 2 diabetes. It usually takes years and years and years for this to develop. So here's somebody's plasma glucose over the years. Here's the top of normal. And here's their plasma insulin. So for many years, when somebody is pre-diabetic and early diabetic with type 2 diabetes, they have normal or elevated insulin in circulation. But remember, it's their tissue. It's their tissue that's becoming less and less sensitive to insulin. So guess what? The body's trying to respond by releasing more and more and more insulin. Unfortunately, you can get to what's called beta cell burnout. These beta cells are working for decades, and at some point, they start having a diminished capacity for releasing insulin. Later on, this is in an uncontrolled diabetic. This is considered the natural course of uncontrolled type 2 diabetes. So one thing that's quite different in a newly diagnosed type 1 diabetic versus a newly diagnosed type 2 diabetic, and a newly diagnosed type 1 diabetic, there's low or almost no insulin. With a type 2 diabetic, insulin is elevated. It's elevated for a long period of time. Look at the number of years. You're looking at more than 25 years before they get back to being insufficient insulin secretors. And this is based on a lot of different studies. Yeah?
So 2 questions. So would you be more likely to see somebody that's going to be type 2 diabetic more on the lower end of their glucose, their blood glucose levels?
Now say it again.
Is it better, or would you see it if somebody's going to become type 2 diabetic 5 years, 10 years from now? If you took their blood glucose level, are you more likely to see it on the lower end because of that extra insulin in their system?
Well, you can see glucose is just gradually increasing. It's gradually increasing. Now, the great thing about prediabetes and type 2 diabetes, at least early onset type 2 diabetes, is you can cause regression. In 70 to 80% of patients, but it gets to compliance by dietary changes and changes in physical activity, you can regress and go back to a much healthier state. It was thought for a long time that type 2 diabetes is a chronic progressive disease, but research being done right now in England is very much showing that, I'm not going to have time to talk about it, there's certain manipulations that one can do that half of the people who are diagnosed as diabetic, you can take them off all diabetes medications, but it's a pretty radical lifestyle change. But somebody who's heavy, it's interesting, if somebody's 40% body overweight, if they lose 1/3 of that, their diabetic symptoms pretty much go away. You don't need to lose all, you need to lose about 1/3. And bariatric surgery weight loss surgery causes a rapid regression. It's interesting that with bariatric surgeries, not all, but some, that in type 2 diabetics, that even before they start losing weight, their glycemic control increases, just like within 2 months. But a lot of bariatric surgeries, people regress and gain weight in spite of that 5 years later. So patient compliance is a very difficult thing. So here's the problem with type 2 diabetes. It's at the effector cells. It's at the effector cells. So I think this is the slide you have. So with type 1, it's at the beta cell problem, and with type 2, it's an effector cell problem. You have this decreased sensitivity to insulin. So I did want to talk to you a little bit about, there is normal hyperglycemia and there's abnormal hyperglycemia. If you eat that bagel with, I'm going to say plum, wild plum jam today, and orange juice, yep, your plasma glucose is going to go up as those carbohydrates are digested and then absorbed into the bloodstream. Plasma glucose goes up. But 1, 2, 3 hours later, that glucose is going back down to normal. That's a normal response. That's a normal response. Somebody who is an uncontrolled diabetic, it might look more like this. And those of you who have worked with in clinical offices, especially if you work with somebody who's in internal medicine or an endocrinologist, every part of this slide means something to them. And there are oral glucose tolerance tests where somebody comes in fasted state, you give them X grams of certain forms of carbohydrate, and then you look at these curves. And a normal person, it goes up, glucose goes up and comes down. And an uncontrolled diabetic, their fasting glucose, they come in higher. This initial rate of increase is actually steeper. The peak is higher, but what's very obvious to everybody is return down to baseline is much delayed. Now, people who work with these patients all the time, they're very much interested in this area of the curve. Let's say you do a glucose tolerance test right here, and the curve in the normal person, if you measure the area, that's what AUC, area under the curve, that's what it would be for a normal person. For a person who's an uncontrolled diabetic, there's a much increased area under the curve. So they look at fasting, they look at peak, they look at this rate of increase, and they look at area under the curve. And all those things can be calculated to really look at what's the degree of dysfunction here. So how does one look at long-term glycemic control? And many of you have heard about the hemoglobin A1C test. It's used to determine long-term glycemic control. If you do a finger stick blood sample, it tells you a snapshot is what is somebody's blood glucose right now. And yesterday in the morning, I have a little glucometer that I use for kicks and grins. I had a number of emails that was like, oh my gosh, it was just my other students, and it's like, oh gee whiz, we need to deal with that. So my sympathetic nervous system was turned on a little bit even before I ate breakfast, and I was like, well, let's check. It was 106. So I was just a little bit above normal. But this is, so that was just a snapshot of what my glucose was at one time. Now clearly after a meal it's going to go up. In the evening it's going to go down. But what's your average glucose? Well, looking at this hemoglobin A1C subunit, so this is a subunit of a hemoglobin molecule. It has an amino acid that is susceptible to being glycated by glucose. So if you have persistently elevated plasma glucose, this can lead to the pathological glycation of proteins throughout your body. And unfortunately, these glycated proteins throughout the body either become structurally or functionally impaired, or the body's immune cells recognizes them as foreign. So the higher your average glucose is, the more of this glycation occurs. These proteins in your blood, along your vasculature, and it's actually tissues throughout the body. So your higher the glucose, the more that glucose can react and stick to these different proteins. So The hemoglobin A1C glycation test is used as an index to just go, what is this person's overall glycation throughout the body? You don't want somebody sticking a cannula and pulling out a piece of muscle and a piece of fat. That hurts. Just give a blood sample, and the hemoglobin protein on red blood cells has one of these proteins that's susceptible to glycation. And actually, if you glycate this hemoglobin, the hemoglobin still works. But if you look at the degree of glycation of that hemoglobin, it tells you the degree of glycation throughout your body. Okay? So it's an easy thing to get that blood sample. It's an easy test to do. Red blood cells have a lifespan of 3 to 4 months, and therefore the percent hemoglobin A1C glycation tells you what has your glycemic control been for the last 3 to 4 months. So it gives you an estimate of average plasma glucose. And you won't be able to see this, but for example, if you look at this table, a person with 7% of their hemoglobin A1C subunits glycated, that means that their average glucose was 154. It was 154. Now, you go, boy, that's way too high. But, you know, somebody who, your glucose isn't always 70 to 100 in a normal, healthy person. After a meal, you become appropriately hyperglycemic. So your average estimated glucose might actually be more like 110 or something like that. And this woman, that one article, that young woman who ended up in the hospital 3 times with diabetic ketoacidosis, her average glucose for the previous 3 to 4 months was 470. That's causing damage throughout the body. Damage to neurons, damage to blood vessels, damage to the retina of the eye, all sorts of terrible things. There's nothing for you to really take away from this other than as body mass index goes up. So what this is looking at is body mass index. So as we go to the right, people are getting heavier and the incidence of type 2 diabetes goes up. And these colored ones are physical activity. And people, even if they're a little bit heavier, if they are physically active, their incidence of diabetes is much, much, much lower. So physical activity and, well, I should say physical inactivity and being overweight causes a big impact on that. Genetics also play a role. Now this one is really why I put this slide on here, because this kind of grabs me. Here's somebody who has a hemoglobin A1C of 11%, 10%, 9%, 8%, and 7%. And they follow these patients for years and years and years. And what's the incidence of having retinopathy? Remember seeing those small blood vessels burst and having areas of hemorrhage? That's due to disordered polyol metabolism. The higher the glucose, the more retinopathy. Look, if somebody has a hemoglobin A1C of 11%, meaning high glucose all the time, they have a much increased risk for eye problems, and it occurs much sooner. So the better the glycemic control, the less the incidence, and if it does occur, it occurs much later. So glycemic control is absolutely, and so this is just the retina. This also, similar curves are seen for, with kidney. It's seen for coronary artery disease, seen for stroke, incidence of stroke. So glycemic control is very important. So diabetes mellitus overview, type 1 diabetes, less than 10% of all diabetes mellitus cases. It's actually 5 to 7% in this country. So type 1, it's out there. Type 2 is much more common. Type 1 classically presents in children and teens. That was the classic thought. And like I mentioned to you, it's now known more than 50% occurs in people after age 20. So it was just so obvious in children and teens. The onset of symptoms is rapid. That doesn't mean that the disease process didn't start years before. It's just symptoms and signs occur very rapidly. So common signs and symptoms include sudden weight loss, polyuria, they urinate a lot, thirst, they're thirsty because they urinate a lot, elevated glucose. Ketoacidosis is seen, diabetic ketoacidosis is seen in poorly controlled type 1 diabetics. I don't know if we're going to get a chance. This is a very dangerous emergency situation where the body starts producing a very large amount of ketone bodies, and that causes acidosis. And think back to part 1. Why do we worry about acidosis? Well, why do we worry about respiratory acidosis or metabolic acidosis? pH affects the function of proteins throughout the body. Go back to the homeostasis lecture. We have all these different things that are homeostatically controlled. So you have transport proteins, you have binding proteins, you have enzymes, you have all sorts of proteins throughout the body, and they work in certain pH windows. If people become acidotic or alkalotic, these proteins that give us function, they start to dysfunction. So diabetic ketoacidosis is a true emergency situation. It's seen in poorly controlled type 1 diabetics. It's very rare in type 2 diabetics. Type 1 diabetics associated with immune-mediated loss of pancreatic beta cells and loss of circulating insulin. Type 2 diabetes, it's more than 90% of the cases of diabetes in this country. Classically presents in adulthood, but that is changing. As children are becoming heavier and heavier in this country, it's being diagnosed, and less physically active, you're seeing diagnosis of it earlier and earlier and earlier. It typically takes years and years to progress, often associated with family history, genetics, obesity, physical activity, and diets in there too. Type 2 diabetes is often secondary to the development of insulin resistance. That tissue becomes less and less sensitive to insulin. With both type 1 and type 2 diabetes, you have that poor wound healing when the glycemia is poorly controlled. And the susceptibility, this is interesting, the susceptibility to hypoglycemia is actually increased in people who are being controlled very tightly for their glycemic control. So you want good glycemic control, but those patients may be more susceptible, well, there's no doubt that they are more susceptible to hypoglycemia. Too bad we can't really get into this, but the non-pharmacological management of diabetes is diet, exercise, weight management, and there's a lot of studies going on right now looking at how to do exercise prescription, and it's becoming more and more obvious that you don't need to do tremendous amounts of exercise to achieve really good glycemic control, well, better glycemic control. So here are people that just exercise 3 times a week, and they just pedaled on a cycle ergometer hard for 60 seconds, relaxed, hard for 60 seconds. They did it 10 times per session, 3 times a week, and this is how much GLUT4 changed. The glucose transporter changed, and this is how much better the glycemic control went down. Now, I'm not suggesting you're a patient, you go out and tell your patients, you need to do all-out bursts of 60-second exercise. Other bad things can happen, but it turns out that you probably don't need as much of the duration of exercise to have really good glycemic control. I already mentioned that exercise will stimulate glucose transporters. I go out exercising on the Mopac Trail, and here's some ladies that I just always love running into and talking to. It's kind of hard for you to see, so there's a lot of great things in this photo. Number one, we're not in town. We're out in the country. Mm-hmm. So they're not ball walking. They're out in the country. They're doing it out here. Notice the spike cane? She can't see. I don't know if you can
Oxygen.
see this. She's on oxygen. You can't see it. She's got a walking boot. Why the hell am I not out there every Monday, Wednesday, Friday? They are every Monday, Wednesday, Friday. You know, every Monday, Wednesday, Friday. They're going out, they're getting their 3-mile walk in. And, you know, that's amazing. Can't really talk about this. I'm just going to buzz through this because it's just kind of fun, and this is what you're going to get in pharmacology. This is the, so you're not going to, I might mention a couple things to you, but you don't need to really study this. But I do want you to look at rational drug design. So you know now all these different ways of glycemic control. So there are, for example, drugs out there that are given, this is for the treatment of type 2 diabetes. I just want you to visualize how drugs are formed. But there are insulin sensitizers. The most common one is metformin. It's a first-line drug in a diagnosed diabetic. And what does it do? It actually decreases insulin, it decreases insulin resistance, so it increases insulin sensitivity. And as a benefit, metformin also decreases gluconeogenesis. So that's one way of helping treat glycemia. Sometimes patients, even type 2 patients, are given insulin. Okay, you know what that does. Sometimes some patients are given these alpha glucosidase inhibitors. What do these things do? They inhibit the breakdown of carbohydrate in the GI tract, so therefore less is being absorbed. That's one pharmacological route that one can do. Sometimes some drugs in some patients are given that actually will stimulate pancreatic beta cells to release more insulin. They're called secretagogues. And so here's some drugs that'll do that. So these cells will make more insulin to overcome this insulin resistance. Yeah, here's the insulin sensitizers, I guess I got out of order. Metformin is one of the foremost drugs given to a type 2 diabetic. Here's a new group of drugs, not new, they've been out for about 10 years, but they're GLP mimetics, and these are very interesting because these do two things at once. They increase the health of beta cells, causing them to be able to release more insulin, and at the same time, they inhibit the release of glucagon. That's a nice trick. It's a real nice trick. Your body has incretins that do the same thing. When you exercise, you stimulate the release of incretins, increasing the health of your beta cells and inhibiting the release of glucagon. But in your body, there is an enzyme that will put the axe to or degrade these incretins. So guess what? There are drugs that inhibit that DPP4. So your own body's incretins are now allowed to work. So all these are pharmacologic strategies. Different patients need different strategies. This is the one that you see a lot of commercials on if you do watch television. As you know, as glucose is filtered by the kidney, it's reabsorbed back into the bloodstream. There's two different, and normally there's no glucose in the urine. There's two different sodium glucose co-transporters, and it's the SGL2, the sodium glucose transporter 2 protein, that there's now two different drugs that are commonly prescribed, and these are considered almost breakthrough drugs, that they decrease the sodium, the glucose reabsorption. So guess what? Some glucose does come out in the urine. So that's getting rid of some of the glucose. Now, in a type 1 diabetic, that's considered a bad thing, but pharmacologically, that is considered to be an okay thing. Water follows that. People tend to lose a little bit of weight. It also causes their blood pressure to go down. They're losing extracellular fluid volume. They are at an increased risk for urinary tract infections. Glucose down there causes urinary tract infections. Lots of people are considering these drugs as absolutely changing their clinical practice and how they're managing patients.
So could that also be used in, well, never mind.
Okay.
Never
These insulin sensitizers, other than metformin, do have a history of having some problems with causing some other problems in the body. So this is kind of the slide that I gave you. I'm not expecting you to know this, but I may ask a question like, okay, you have a drug, this metformin, and I'll tell you what it does. I'll tell you exactly what it does, and you predict what the outcome would be, okay? So there's all these algorithms that you're going to work with. Somebody comes in, the first thing you're going to try is lifestyle modifications. That doesn't work. They often get metformin, and then there's many different decision trees like this. Some are based on cost, some are based, and there's a much better one well, there's many better ones out there. This is the simplest one, with how to decide what's second therapy, what's third therapy, and if none of that works, then you back off on everything and you just stay with metformin, and then you do insulin multiple daily injections. So there's a lot of different strategies, and different clinicians do different strategies. All this is saying is hypoglycemia is a problem in tightly controlled diabetics. The more drugs you give to control the diabetes, they do have a chance for hypoglycemia. We won't have a chance to go through this. This is pretty heavy biochemistry, so it's probably best we don't. So here are the questions, and if you can get through these questions, you're going to do just fine on the questions for this. So our unit exam is going to be that end of cardiovascular to right now, and the sorry I'm taking a little bit extra time, but the final exam is really going to be the Unit 1 and Unit 2 material. Yes, some of that Unit 1 and Unit 2 material is going to pop up on the Unit 3 exam because we learned those foundational physiologic mechanisms to apply later on, so some of that has to come. So somebody mentioned something yesterday that I would be happy to do. If anybody would want to, one thing we haven't gone over is your Unit 1 and Unit 2 exam. Do an old exam dissection of those two exams. They're going to be different questions, but it's all the same concept. So if any of you, if you have any time that you want me to come and we can talk through the questions and the responses for exam 1 and exam 2 to help you review that material, I'd be happy to do that. We can work out time to work with it, okay? So it's been a pleasure being with you this semester. Really, really, really.